Hi, I'm Chris Wallis. I'm a urologic oncologist at Mount Sinai Hospital and University Health Network in Toronto, Canada. I'm here today with a distinguished panel to talk to you about advances we're seeing in non-muscle invasive bladder cancer. So I'll have the panel introduce themselves, starting with Sia next to me.
Thank you. I'm Sia Daneshmand, Director of Urologic Oncology at the University of Southern California in Los Angeles.
Hi, I'm Piyush Agarwal, Fellowship Director and Director of the Bladder Cancer Program at the University of Chicago.
Hi, my name is Sima Porten. I'm the Fellowship Director and a urologic oncologist at UCSF.
Thanks, everyone. So we're going to get into a discussion really about one of the fastest moving spaces, I would say, in urologic oncology right now, non-muscle invasive bladder cancer. We've seen a lot of changes, I would say, towards the end of this disease space for a few years, and we're starting to see the changes sort of migrate earlier and earlier. So maybe just to begin with some level setting, can one of you guys take me through AUA, SUO, risk stratification for non-muscle invasive bladder cancer? This isn't a one-size-fits-all group of patients.
Yeah. Maybe I can take AUA and you guys take the rest. So, yeah, the AUA guidelines, we have the risk categories, low, intermediate, and high-risk patients. The easiest way to think about it is any patient with high-grade disease that's more than 3 centimeters, so the bigger tumors, CIS, high-grade T1, they all fall into, obviously, the high-risk category, and it's the same for European guidelines as well. Then we have the low-risk patients. These are going to be low-grade TA tumors and high-grade tumors that are small. That's the difference between the AUA and the EAU guidelines. And everything else falls sort of in between. So if you have a high-grade TA tumor more than 3 centimeters, or you have recurrent low-grade tumors, then that falls sort of in that intermediate risk group because they have higher risks of recurrence. So we want to treat them a little bit differently than your true low risk.
And there's some nuances with some of the staging, if you believe it really is a low-grade T1, then that might fall in the intermediate risk category. A lot of pathologists don't really think that exists. It's sort of a zebra. But and then some people will look, some stratification will include high-grade TA that's less than 3 centimeters, although I personally treat those as high-risk patients.
And then I think some of the newer release of the EAU guidelines, and then also you see the little stars on the AUA guidelines at the bottom, kind of denoting this very high-risk group of patients. For AUA, that's those with variant histology, lymphovascular invasion, and EAU actually has an age cutoff for their very high-risk group, over 70. And so I think as we get more and more data from patients in the U.S. and also internationally, I think we're going to be able to better refine some of our risk stratification tools.
Absolutely. And I think maybe one of the takeaways I got from the way you guys described it is, we have a fairly clear sense of low risk and a moderately clear sense of high risk. And then intermediate risk is this like non-low, non-high kind of grab bag group of patients with a lot of heterogeneity in terms of, is it an initial presentation? Is it about recurrence? Is it about grade differences or multifocality or size? There's all these different characteristics that make for a real sort of heterogeneous group of patients. And so that said, what features would make a low-grade patient, maybe Dr. Agarwal, you want to take this on, an intermediate risk? So
someone who's had multifocal tumors. So some of our low-grade will just have a single papillary tumor, but multifocality is considered to be more aggressive and therefore elevates it to intermediate risk. Tumors that are greater than 3 centimeters in size, so that is also an intermediate risk category. And then finally, those patients who recur within less than a year from a previous low-grade tumor. So early recurrences or frequent recurrences would be a third distinction of intermediate risk.
Let me ask a silly question. How do you measure your tumor? Everybody, the answer is obvious when it's like 5 millimeters, and the answer is obvious when it's 8 centimeters. But how do you tell how big a tumor is when you're resecting it?
I'd love to hear your responses because I'm not sure.
I think all three of us should respond. I think that's a great question, actually, and that's why we are uncomfortable with this 3 centimeter cutoff for intermediate risk versus high risk, and the European guidelines don't make that distinction. It's difficult, isn't it? And it's very inaccurate. Is it flat? Is it papillary? Is it a solid tumor? The easiest way, what we sort of teach residents is your loop. If you have a 27 French scope, it's going to be 9 millimeters. If you go right up next to it, it's how many scope lengths is the tumor. That's your sort of one size is like width, or, but then there's width and there's height and there's volume and all sorts of things. So, I think it's very inaccurate. You're right that the smaller ones are easy. The really big ones are easy. Those in between. And then also on occasion, you can see it on imaging. So you'll have a CT scan, you go in there like, oh, this is definitely more than 3 centimeters. And you do have a CT, a very good imaging study, an MRI showing it's actually 1.5 centimeters, what you're looking at if it's a solitary tumor, right? So they're like, okay, well, and then there's all this billing issues that, have different codes for different billing. And I think sometimes they're maybe a little bit over exaggerated. For that reason, in some of the large databases that we look at in the community, you certainly see the billing codes being upshifted for those size.
Yeah. We use the loop technique too. I also say that, once you've resected the tumors, like just look and see and measure it on the table in the back, and kind of get a little sense of, is it as big as you thought it was? Is it not? And then, sometimes when we see second opinions and things, you'll read an op report. There's some billing stuff that goes along with our size estimations, and also it's hard to estimate size when something is magnified. But every pathologist has a gross description, and it actually measures the tumor in 3 usual areas or sections, and that can give you a little sense of small, medium, big. I think that's what you get
on block. If
that's
you
true.
have
If it's just
multiple
chunks,
pieces, it's
it's
still
harder
hard
to do it.
Yeah.
It's a little bit of a off the backhand estimation too.
I propose we do weight-based. What do you think of that?
They also weigh
The
ours too.
pathologist,
They
has
also
a
weigh ours,
weight,
yeah.
and I think sometimes you have multiple
Sure.
papillary tumors over a 3 centimeter area, and you're resecting that 3 centimeter area, but really your papillary tumors are each half a millimeter, right?
Yeah.
In each section.
true.
So how do you measure that?
Yeah.
But if you do perhaps volume, but then on the flip side of it, as a pathologist, you're giving benign tissue as well.
Yeah.
So you're weighing both benign and
Ideally, we're sampling some muscle that's not involved there.
right.
Yeah.
Right. And muscle weighs more.
Absolutely.
Yeah.
Right.
So we do these risk groups to try and understand the natural history or the future for these patients and guide our therapy. So what's your thoughts on progression risks versus recurrence risks for these patients, and how we, how that maybe shapes how we need to think about therapies? What are we really trying to prevent? Is it progression in that intermediate risk into a high risk or a muscle invasive disease, or is it just recurrence of more of the same? Maybe Dr. Porten, you want to take that first?
I think I would say both. Obviously, a grade reclassification to something high grade, about 10 to 15% of folks who truly are these recurrent low grades, right? You definitely want to prevent that, because in terms of what is a threat to someone's health, that is probably one of our tasks to do that. But recurrences can still be burdensome. And so I think that can also really reduce patients' quality of life. So from that sort of perspective, you want to kind of mitigate that as much as you can, so that people can live a joyful, happy life, hopefully free of pain or side effects from recurrent tumors.
Yeah. Yeah, there's a nice paper, Sukup and colleagues, that looked at conditional risk and progression. And so the longer you are free from tumor, the less your progression and recurrence rate are. These tumors, unfortunately, a lot of times they happen at short intervals, every 3 months. If you get up to 6 months, recurrence rate's about 31%, and the progression rate is somewhere kind of in the 7 to 8% at 2 years. So even over 2 years, you have a very low progression rate. And so, but those ones that recur frequently, the progression rate's a little bit higher. And so one could argue that these patients need a treatment because they have a more aggressive phenotype than other intermediate risks. And this is the problem you'll probably get at, is the heterogeneity to this type of tumor.